This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1040, recorded on August 31st, 2023. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
Last day of August, Daniel.
And the summer is wrapping up, so I'm going to start us with a quotation, a summer ending quotation. What good is the warmth of summer without the cold of winter to give it sweetness? And that's by John Steinbeck. Does that make you feel any better about summer ending, Vincent?
It doesn't bother me because as soon as it ends, it'll be back. That's how I look at it.
I was listening to the Neil Diamond song, America, today. Maybe give people some insight into my musical listening, but he was talking about coming to America and the warmth. And I was like, I'm just hot. I don't want any more warmth, Neil. All right. So a little bit of a theme seems to be emerging over the last year. Leprosy, malaria, dengue, West Nile virus, polio, all here in the U.S. And now the article, The Public Health Significance of Finding Autochthonous Melioidosis Cases in the Continental United States, published in PLOS Neglected Diseases. So just some background. People are familiar with this, but melioidosis is an infectious disease caused by Burkholderia pseudomallei, a bacterial pathogen that can infect humans and other animals. Human case of the disease has been thought to be restricted to Southeast Asia and Northern Australia, where the pathogen is endemic, found in the soil and water. But in recent years, the presence of Burkholderia pseudomallei has been demonstrated in the African and American continents, in the Caribbean islands, as well as the rest of Asia. And now, recently, the pathogen that causes melioidosis was found in the Gulf Coast region of Mississippi, United States of America, associated with human cases. I think we're actually up to 3 cases now here in the U.S. And the CDC&P has declared the pathogen as endemic in the continental United States for the first time. Specifically, the Gulf Coast region of Mississippi has been declared by the CDC as an endemic area.
I just noticed, Daniel, you said CDC&P, right?
Yeah, I'm one of the few people that adds the and prevention. People say the CDC. I'm like, it's the CDC and prevention.
Well, here in Europe, I happen to be in Italy, it's called the European CDC. That's it.
Okay. In China, it's the China CDC. Most of these organizations have dropped the Centers for Disease Control and Prevention part. And we always talk about the ASTM and H, where the H is hygiene. People seem to be forgetting about hygiene and prevention and just sort of waiting to mop up after the fact.
Well, Daniel, prevention, control can imply prevention, right? I don't have a problem with that.
Okay, so let's just do that. Let's decide that control is the new prevention.
Okay.
All right, and let's move on. Now, this one is just a fun up front, fun from interesting, not fun from the human cost here, but lots and lots of texts and questions about this one. I think you even sent something my way, Vincent, about this.
That's right.
But this is the Dispatch Human Neural Larva Migrans caused by Ophidascaris. I'm pronouncing it that way specifically. Ophidascaris robertsi ascarid, published in Emerging Infectious Diseases. So Ophidascaris species are nematodes with this indirect life cycle. They infect various snakes across the old and new worlds as their definitive hosts. These nematodes are native to Australia, where the definitive hosts are carpet pythons. The adult nematode inhabits the python's esophagus and stomach. They shed their eggs into its feces, and then the eggs are ingested by various small mammals in which the larvae establish. Those are the intermediate hosts. Somehow those small mammals end up inside a python. Well, in this case, a 64-year-old woman from southeastern Australia was admitted to the hospital with abdominal pain, diarrhea, dry cough. They see some stuff going on in her lungs. They see elevated eosinophils, some stuff also in the liver and spleen. They diagnose her with an eosinophilic pneumonia. And what do? They put her on steroids. Gets a little better, which steroids will always do. And then 3 weeks later, recurrent fever, cough, more issues, goes on to develop neurological symptoms. They scan her brain. They see this lesion. And when they do an open biopsy, out comes a live worm. And they have some great pictures. This was a live and motile worm that was living in this woman's brain, actually in the front right side of the brain. They treat her with ivermectin. This is a situation where that actually is helpful, by the way. 4 weeks of albendazole. They gradually decrease down the steroids. She does have improvement, but there are some symptoms that persist. So,
Daniel, how did this get there in the first place?
So the idea is just like the intermediate hosts, she probably ingests one of these embryonated infectious eggs. She's taking the place of the small mammal. And so the larvae basically is in her, waiting for her to be eaten by the python.
So it crossed her blood and got into her brain and developed further there.
One of the challenges here is, did it end up in her brain because of all the steroids?
Ah, interesting.
Yeah. So, which you've just ended up with this eosinophilia and ended up with some pulmonary issues and eventually cleared it. How much of this was us taking our hands out of our pockets when they were best left there?
But Daniel, do you think her neuropsychiatric problems are a consequence of finding out she had a worm in her brain?
How traumatic, right? Can you imagine, moving forward, forget about the damage done, just the whole concept that, for months you had this worm, which now, everyone can see that this worm was inside her brain.
She's going to have nightmares for some time, I think.
I'm going to have nightmares for some time after this.
Okay.
All right. Moving into COVID. I had an interesting conversation with one of my colleagues in the hospital this week. Now, he's a cardiologist, but that's okay. I could share what we are seeing. I could share what the CDC COVID tracker has to say. So let me start there, and then I'll kind of get back to this conversation. So as everyone probably is aware, this is now, mainstream news, is we are seeing an increasing number of COVID hospitalizations, not just people admitted with COVID, but people admitted for COVID. We're also seeing about a 20% increase in the COVID-19 deaths, just sort of over the last week. So, we're sitting here, maybe numbers help. So we're sitting here about 500 to 600 deaths per week from COVID. One of the, this is certainly regional. Actually, at the hospital where I was earlier today, calculated the numbers, like how many patient beds, how many patients positive for COVID. 20% of the patients in that hospital have COVID. So this is pretty significant. So yes, we're seeing hundreds of deaths each week. But let's put this in context. And I think it's important that we're honest here. When I say 20%, it's a 20% increase from a relatively low number. So we're still at about half of what we were last year, the same time last year. And we're still about 1/5 of the level where we were in 2021. So and what are the predictions? So what happens next week on Tuesday? My son and many other children head back to school. My daughter Eloise has already headed back to university. My daughter Daisy, a week later, will start nursing school. So summer's ending. We're going to have a lot of people in these close quarters. What are the predictions? We are expecting there to be a continued rise over the next few weeks here. New York, we have the Jewish holidays, which actually we have a large Jewish population. So that's probably going to have some impact as well. So we are expecting something of a rise. And then we're still expecting the big rise to be December, January. So, as we talk about boosters, that'll continue to be relevant. But now back to my cardiologist colleague. The interesting thing about the conversation is people don't want to hear that it's vaccines that are making this mild. They still want to hear that the virus has gotten milder. I'm not sure I understand exactly that. And there also is this continued, maybe people, and actually there's an epidemiologist who's referred to it as we're entering the revisionist phase of the pandemic, where we, and he brought up again, but we don't really have to worry about the children. It was never a problem in children. And I basically said, so are you one of the people who wants to put the word only in front of 1,000 deaths in children? So continues to be a challenge as we move forward. But let me move forward to something I will say is positive, is interesting. We heard that Project NextGen awards over $1.4 billion to develop the future of COVID-19 vaccines and therapeutics. So what is Project NextGen? It's a $5 billion initiative led by the Biomedical Advanced Research and Development Authority, so BARDA, in partnership with the National Institute of Allergy and Infectious Disease, coordinated across the federal government, private sector. So there's a lot of coordination here. And what were the awards that were announced? So $1 billion to 4 BARDA clinical trial partners to support vaccine trials, $326 million to Regeneron for development of next generation monoclonal antibodies, $100 million to the Global Health Investment Corp that is going to manage the BARDA Ventures investment portfolio. That was interesting. Okay. And $10 million to Blue Knight, a joint initiative between BARDA and J&J Innovation to distribute to the awardees of Blue Knight Resident Quickfire Challenge Accelerating Project NextGen. So not sure I quite get what's going on with these last two. But let's talk about what happened in China when the zero COVID policy ended, right? So it takes time. You got to wait. You got to gather the data. And here we have the article, Excess All-Cause Mortality in China After Ending the Zero COVID Policy, published in JAMA Network Open. So these are the results of a cohort study that analyzed published obituary data from 3 universities in China. They did search engine data in each region of China over this period of time. Basically, what they're trying to estimate is how many people died in those 2 months after the end of zero COVID. And they actually came up with an estimate of somewhere between 0.7 and 4.43 million excess deaths among individuals 30 and older just in those 2 months after the end of COVID. So kind of shocking. I don't know, I guess, are we becoming numb to statistics? The idea that, millions of people, maybe 2 to 3 million people died in 2 months.
That's a lot of people, Daniel, but if they had had a lot of Paxlovid, they could have prevented a lot of them, right?
That is the challenge, right? They knew this was coming. They knew they were going, they knew, okay, we are going to decide to just stop this approach. 90% reduction, right? So instead of 2 million, maybe 200,000 could have saved almost 2 million lives.
Yeah, I mean,
and that's something I think will be.
This Paxlovid alone, then you could add Remdesivir and Molnupiravir and maybe get it even lower. And the same with the deaths that you just noted in the U.S. All of those, or many of those, are preventable. If people would just stop worrying about Paxlovid, we could get over this.
Yeah, I've got another story, so we're going to get to that again. So what about children, right? Remember? Only 1,000 children died? Yeah. I'm not one of the people who finds the word only to properly fit in front of 1,000 children dying. The article, International Pediatric COVID-19 Severity Over the Course of the Pandemic, was published in JAMA Pediatrics. So the objective of the study was interesting. So these investigators set out to determine whether the dominant circulating SARS-CoV-2 variants were associated with differences in COVID-19 severity among hospitalized children, right? So thousands and thousands of children ended up in the hospital due to COVID. So clinical data from hospitalized children and adolescents, these are all younger than 18 years of age. These are SARS-CoV-2 positive. They looked at 9 countries: Australia, Brazil, Italy, Portugal, South Africa, Switzerland, Thailand, UK, and the US. They looked at these 3 different time frames, right? So the time frame for the ancestral, we have our pre-Omicron, and then we have our Omicron, respectively. And the age groups for analysis were those younger than 6 months, the 6 to 5 years of age, and the 5 to 18. And if the children just had an incidental test, if they didn't have COVID-19, just an incidental SARS-CoV-2 positive, they're excluded. We're not looking at people who had a positive test. We're looking at people that had the disease. So among 31,785 hospitalized children, right? I just want to repeat that number: 31,785, thousands, tens of thousands of hospitalized children and adolescents. The average age, median age, was 4 years old. I want people to sort of picture a 4-year-old in their head. 16,639 were male, so about half, 52%. In children younger than 5 years across successive SARS-CoV-2 waves, the only reduction they saw was in the percent of the kids that ended up in the ICU, but not ventilator support, not oxygen therapy. Now, if they start looking in contrast, ICU admission, ventilator support, oxygen therapy decreased in the different waves in children 5 years to younger than 18. Now, this was interesting. The results were consistent when data was restricted to unvaccinated children. So what's the big difference here between the really young kids new to this world and the other kids who are out there where we're actually seeing perhaps repeat infections? So very interesting to speculate what's going on here. So what do the authors have to say? Well, they say it may be that the reduced rate of ICU admission over the course of COVID-19 pandemic in children younger than 6 months is reflective of maternal vaccination and or infection, which is interesting, but that's the only benefit they got, right? They just reduced the ICU admission. They also say it is possible that the same effect was not seen in terms of ventilator support and oxygen support because maternal vaccination may be most efficacious in protecting against these most severe outcomes, but not against the moderate outcomes. And the authors also point out that a direct comparison of disease severity between the different age groups, disease severity, was elevated in all children in this first period. And this data was consistent throughout the different parts of the world.
I have to register a little dismay here, Daniel. I don't understand how you could do a study like this and not have all the data. For example, who was born to a mother that had been vaccinated or infected, who got vaccinated. That data would help you know what is going on in terms of immunity, which is likely what is moderating pathogenesis in the long run. But in the end, you don't come out with any real conclusions here, right?
Yeah, I hate to have it sort of, speculation at the end because these are all questions that you can ask and you can say, okay, what if we looked at children whose mothers were vaccinated or got infected during the last trimester versus parents who decided not to get vaccinated? Like you could ask that question in this cohort. Maybe you're not going to get the answer for all 31,785 kids, but if you could get like 1,000 yes, 1,000 no, compare that. Also looking, you can even ask the question, was this, which I always do when I admit someone now, is this your first COVID infection? Your second, your third. So, some of the speculation could actually be addressed. I think that would be helpful.
There's so many confounding factors that could be addressed here. Like if a kid played in the dirt a lot as a young kid and the other one didn't, you got to make a list of all these potential things that could influence outcome. But, I get the impression that the authors just want to take the big numbers, crunch them a bit, and try and get an answer. And that just is not very useful.
Yeah. Yeah. I mean, at least what we are seeing is that for the youngest kids, those, under the age of 5, we really were seeing pretty similar severity. We're seeing, same ventilator support, same oxygen therapy. The only thing they found a statistically significant impact was what percent end up in the ICU.
Daniel, I'm at this clinical virology meeting. I can't tell you how many times I hear somebody say the virus wants to be milder because it can spread better. Okay. And they seem to ignore the fact that even if you die, if in the first 5 days you shed virus and you transmit it, that's all that's needed. So being milder doesn't help with transmission, right? You get what I'm saying?
Well, what you're saying is right on. So let's talk about it. 85% of the transmission is in the first 7 days. People don't die in the first 7 days.
Exactly. Exactly.
100% of the transmission is in the first 10 days. So nobody dies in the first 10 days.
No,
Mortality
no,
does not impact transmission.
no.
Now, if people were dying on day 2, if they were dying during the transmission period, so there's no evolutionary, there's no selective pressure
No.
here on severity. And I
No.
don't know why, what is it? There was some rabbit study once, and everyone like quotes one study, rabbits in Australia or something. So, all right. We're not rabbits. We ain't living in Australia. Let's move on. So this is a good one, because this question. You go in, this happens all the time. I was vaccinating some individuals on Tuesday for all sorts of stuff, and which arm do you like least is usually my question. So which arm do you like least? Does it matter? Should you be getting all your shots in the same arm, all your shots for the same thing in the same arm? What's the story? So here we've got the article: differences in SARS-CoV-2 specific humoral and cellular immune responses after contralateral and ipsilateral COVID-19 vaccination, published in eBiomedicine. So we're going to compare getting all your shots in the same arm or getting your shots in different arms. So here they ask this question, and specifically we're going to look at, should you get the booster in the same arm or should we switch things around? Now, these are the results of an observational study, so people weren't randomized. So maybe people are a little different. And actually, if you think about it, you might be a little different if, maybe you got that first shot and you said, oh my, let's try the other arm this time. So here, 303 previously naive individuals, now they're no longer naive, were recruited who received the second dose of COVID-19 vaccine BNT162b2 on either the same side, we've got 147, or the opposite side, 156, and spike-specific IgG avidity, and neutralizing antibodies were quantified using ELISA and a surrogate assay 2 weeks after dose 2. A subgroup of 143 individuals, we've got 64 ipsilateral, 79 contralateral, were analyzed for spike-specific CD4 and CD8 T cells using flow cytometry. And unfortunately, I don't get to see the flow cytometry, just the data. So the median spike IgG levels did not differ, same side as opposed to opposite side. IgG avidity was also similar. However, differences in neutralizing activities were statistically significantly different between the two groups, reaching a p-value of 0.024. And the spike-specific CD8 T cells were statistically significantly impacted. Good p-value there, less than 0.05. Spike-specific CD4 T cell levels were similar, but showed statistically significantly higher CTLA-4 expression after contralateral vaccination. So looking at the actual data and degree of overlap, which I've got kind of up here for you to see as well, Vincent, I'm not sure how impressed I am that the statisticians were able to find a difference.
Yeah, this is a case where don't be taken by the statistics because those look pretty similar. And as you say, probably not clinically significant.
Yeah, it's one of those things where they looked at so many variables that you start to, should you start to do some kind of a correction, or are you going to just keep doing t-tests until you find one that works?
That's right. That's right.
Yeah, so that's.
I mean, basically,
so,
Daniel, I don't think it matters what arm you get it in.
Unfortunately, I don't think it matters either. I just get all my shots in my left arm because I don't like my left arm. All right. All right. So boosters, we're actually starting to get some more information, or information is starting to be gotten. I'm not sure we are getting it, but we have the press release. You ready for that press release? Pfizer and BioNTech received positive Committee for Medicinal Products for Human Use opinion for Omicron XBB BioNTech.1.5 adapted COVID-19 vaccine in the European Union. So just as people remember, we had our bivalent back in the fall. Oh, no, spring, I guess. Now, for the fall, the plan is to get this monovalent XBB.1.5 vaccine. And to get this committee opinion, they actually had to submit preclinical data showing that the Omicron XBB.1.5, basically the new COVID booster, generates an immune response against multiple XBB-related sublineages, including, well, not surprising, XBB. 0.1.5, 0.1.16, 0.2.3, and EG.5.1, the Eris variant. But what about the other variants, which seem to be even outcompeting the Eris so quickly? And they say that the doses are basically ready to ship as soon as they get approval. All right. Vincent takes a deep breath. All right.
Good thing these are not mandatory, Daniel.
All right. So now you are here, you are there. Who knows where you are, but you test positive, you have symptoms, you've got COVID-19. What do you do? So, number one, I'm going to say this. Paxlovid, right? Within the first 5 days, you call your doctor, check the kidney function, check the drug-drug interactions. Well, I recently had a visit with one of my patients who, dare I say, made the mistake of going to visit Florida. And while in Florida, this high-risk individual tested positive and went into an urgent care clinic. They confirmed the test, and then my patient said, so doctor, would you be willing to call in some Paxlovid for me? And what did the urgent care doctor say? Oh, we don't prescribe that here. We are too concerned about the risk of rebound and death. So if you really want that, I will only give it to you if you sign what we call the death waiver. You have to accept responsibility should you have rebound or die from the Paxlovid.
Did he
Isn't that
sign
shocking?
it? Did he sign it?
No, he called me. It's a little bit taken by this whole, you need to sign a death waiver. So
ridiculous.
It's just, it's trouble. It's troubling. It's ridiculous. So yeah, what happens when this individual or an individual who isn't one of my patients, ends up in the hospital, ends up dying? There should be responsibility here. And, it's probably the same doctors giving out Tamiflu on day 3 and 4, which does nothing, and giving antibiotics for those other viral illnesses. But here we have an effective 90% reduction in progression medication, and he's getting his information from I don't know what source, but not from the literature.
And that's why all those people are still dying that you mentioned earlier, because this happens over and over again.
Yeah, I don't know if I mentioned last week, but it was a little troubling. I was talking to the daughter of an older woman who recently died in a nursing home, and she was a little bit beside herself because here in New York, her mom was in a nursing home. The roommate tested positive for COVID. Her mom then tested positive, had symptoms. No treatment was offered. They, told her it would all be fine. And then her mom died. And now she is basically realizing, like, I should have asked, and was asking me, like, should she have gotten Paxlovid? And, the answer is yes. So, these 500 people who are dying every week, common denominators, they're not getting treatment. So preventable deaths. All right. Let's talk a little bit about the Remdesivir, right? So Paxlovid's one option. I had a patient today who was on a atrial fibrillation medicine, so not able to get Paxlovid. So Remdesivir is sort of the thought there. What about this issue of early 3-day Remdesivir? So we've talked about the impressive data from the Pine Tree study, right? So if you're in the first 7 days, only 3 days of Remdesivir is going to get you that 87% reduction in progression, right? If you're in that 8 to 10 days, that little window where you end up in the hospital, but still before day 10, you're not in the ICU, that's when you're looking at that 5 days Remdesivir. But now we have the article Clinical antiviral efficacy of Remdesivir in coronavirus disease 2019, an open-label, randomized, controlled, adaptive platform trial, PlatCove, published in JID. We've got some more data here. So these are the results of an ongoing multi-center, open-label, controlled, adaptive pharmacometric platform trial looking at low-risk adult patients with early symptomatic COVID-19 randomized to one of 8 treatment arms, including intravenous Remdesivir. It's 5 days here or no study drug. And the primary outcome was the rate of severe acute SARS-CoV-2 clearance in these duplicate oropharyngeal swab LUTs. And this is a modified intent to treat. The 2 study arms enrolled 131 patients. So we've got, in these 2 study arms, Remdesivir for 67, no drug in 64. And they're going to do a whole bunch of swabs, actually a total of 2,356 qPCR reactions. And not surprising, you actually have Remdesivir accelerated the mean estimated RNA copy number. So the reduction in that RNA copy number. And you can imagine that I changed that from viral load to RNA copy number reduction. All right. Number 3, Thor's hammer, molnupiravir. Number 4, convalescent plasma for immunocompromised COVID-19 patients at high risk in that first week with no other options. Remember to email Arturo Casadevall if you're having access issues. Let's avoid doing those harmful, useless things. All right. So now this person progresses to week 2. They get a significant early inflammatory, lower respiratory hypoxic phase, right? So this is week 2. We see this in about 20% of folks, whether or not they get treatment at that first week. But if they get treatment in the first week, they are 90% less likely to require medical care during this period of time. If they do require medical care, so let's talk about 1, steroids at the right time in the right patient. So remember, this is, it's always hard, what is the most important and least reliable is the history. You're trying to get that symptom onset. But if they're hypoxic, you're probably getting into week 2. If the oxygen saturations are less than 94%, remember that's the dexamethasone, 6 milligrams a day times 6 days. We get a lot of questions. When did it change from 10 to 16? Well, we talked about the article Optimal Duration of Systemic Corticosteroids in Coronavirus Disease 2019 Treatment, a systematic review and meta-analysis published in OFID. And this was that analysis that looked at 13,404 hospitalized COVID patients, 7 RCTs, 2 observational studies, found no benefit extending that beyond 6 days. And I'll leave a link in here so people can have that when they want to update those order sets and treatment recommendations. 2, we have anticoagulation guidelines from American Society of Hematology. Pretty much across the board, we are recommending anticoagulation unless there's a risk benefit that pushes against it. 3, pulmonary support. Now, this is, I think, a really important article. The article, Clinical Outcomes associated with overestimation of oxygen saturation by pulse oximetry in patients hospitalized with COVID-19, published in JAMA Network Open, right? So this is, they put that little thing on your finger or your ear. They say, oh, your oxygen saturation is great. Doesn't seem to make sense. Maybe they do a blood gas and they say, oh my gosh, your oxygen is actually much lower. So really glad to see this article because this is something we were seeing quite often. And you'll sort of realize which patient population we saw it in. So in this cohort, we have 24,504 patients with pulse oximetry and that arterial oxygen saturation measurement done at the same time. The pulse oximeters more commonly overestimated the oxygen saturations in which patients? Those from minority racial and ethnic groups, and led to delayed recognition of need for COVID-19 therapy among Black patients compared with white patients. And in a subset of over 8,000 patients without immediate need for COVID-19 therapy on admission, overestimation of oxygen saturation was associated with delayed delivery of COVID-19 therapy. So let's just go through a little bit of the details here because among 24,504 patients with both measurements done, 41.9 were female, 16% were Black, 32.2% Hispanic, Asian, Native American, Alaska Native, Hawaiian, Pacific Islander, or any other race or ethnicity, 10.4%, and white, 41.4%. Now, this is sort of interesting. So we talked about the delay in treatment. We talked about this overestimation. They did not find, so there was no association of unrecognized need for COVID-19 therapy within hospital mortality or length of stay. So pretty wide error bars on this study. All right, number 4, we've talked about hospitalization, remdesivir still in the first 10 days, right? So 0 to 7, 3 days, 8, 9, and 10, 5 days. Still in some cases, immune modulation with tocilizumab or baricitinib, really only using those antibiotics in the appropriate context. And getting ready to wrap us up the late phase, the risk of autoimmune diseases following COVID-19, the potential protective effect from vaccination, a population-based cohort study published in eClinical Medicine. So here's this question. Lots of people are worried about those vaccines, but can the vaccines not only protect you against hospitalization, death, ending up in the ICU, but can the vaccines maybe protect you against autoimmune disease? So these are the results of a retrospective cohort study conducted in Hong Kong. The study included over 1 million COVID-19 and over 3 million non-COVID individuals. Compared with non-COVID controls, patients with COVID presented an increased risk of developing pernicious anemia, adjusted hazard ratio 1.72, spondyloarthritis, adjusted hazard ratio 1.3, rheumatoid arthritis, adjusted hazard ratio 1.29, other autoimmune arthritis, adjusted hazard ratio 1.43, psoriasis 1.42, pemphigoid 2.39, Graves' disease 1.3, antiphospholipid antibody syndrome 2.12, immune-mediated thrombocytopenia, that's where the platelets drop, 2.1, multiple sclerosis 2.66, so 2 to 3 times more likely to get multiple sclerosis, and then vasculitis. Now, among COVID-19 patients, completion of 2 doses of the COVID-19 vaccine was associated with a decreased risk of pemphigoid, Graves' disease, antiphospholipid antibody syndrome, immune-mediated thrombocytopenia, lupus, and other autoimmune arthritis. So
How much of a decrease, Daniel? Do you know?
they were all different. They calculate them for the different, So I will recommend people read this. It's worth reading because it's quite a lot of numbers here as far as the increased risk and then the potential benefit reduction with the vaccines. And remember, this is just 2 doses. This is not, as we would say, completing the 3-dose series. All right. And I will finish with no one is safe until everyone is safe. I was recently in Switzerland. People probably know that. It's in the Geneva canton where air conditioning is not legal, and it was 104 degrees. So it was very hot. Maybe that's why I'm looking forward to winter a little bit. But it was interesting because my brother-in-law is part of the U.S. mission to the UN. And there's still a lot of concern, as he was saying, about the therapeutic differences with regards to COVID-19 between the West and particularly a lot of parts of sub-Saharan Africa. And by therapeutic, he's talking about vaccines, medicines, a lot of these different things. So I want people just to remember this, that, we're all in this together. No one is safe until everyone is safe. Hoping everyone would pause recording right now, go to parasiteswithoutborders.com and click on the donate button. We are trying to raise enough money to give a donation of $20,000 to floating doctors down there in Panama. I'll be down teaching there in December again. But all donations, August, September, October, we will double up to this potential maximum donation of $20,000.
It's time for your questions for Daniel. You can send them to daniel@microbe.tv. We have a letter here from Kathy Spindler, one of the TWiV hosts.
Oh, I know Kathy. Hey,
It's
Kathy.
all about Paxlovid prophylactic prescription. I wrote to my University of Michigan doctor, who I talked to in person in May before the FDA approval. For my upcoming trip to Croatia, I was hoping to get a prescription to take along. Here's what he wrote back. Is this your experience too? I checked with our pharmacy and infectious disease teams. Unfortunately, even though Paxlovid is FDA approved, it can still only be written for treatment of active COVID and can't be given for prophylaxis to bring abroad for travel. Seems silly to me, but unfortunately, our hands are still tied.
Yeah, so your hands are not tied. Actually, you probably remember this, Vincent. Vincent, you and I were sort of on this group discussion, and one of these social media influencers, Jamie from out in the LA area, was talking about how there were certain different economic groups that were even under the EUA getting Paxlovid for travel, but Jamie is a man of color, and he's like, it surely isn't happening for people in my particular racial group. And so people were doing this even before you really could. Right now, Paxlovid, it is a licensed medication. And licensed medications, one of the deals is physicians are allowed to use it off label. So yes, your doctor can go ahead and your doctor can actually use it off label. We talked about when I was training, we had at that point no FDA approved medications for rate controlling people's atrial fibrillation. So we used medicines that we knew worked. So, someone is traveling, Kathy, your age alone is going to put you at high risk. I don't know the rest of your medical history. When you travel, you should have some rapid tests with you. But what's going to happen, right? You're in Croatia, you test positive. Are you going to be able to get Paxlovid within the first 5 days? Are you going to be able to get 90% reduction? It actually makes a lot of sense, and it is definitely okay to use medicines off label. So, Kathy, give me an email. Should you put us in touch? Kathy has my email, so she can just call me too.
All right, Marianne writes, what is the bell curve, perhaps, which you see for severe RSV infections in the 60 plus population? I am generally wary of new vaccines for a few years until more data are collected about adverse events. The exception was the COVID vaccines boosters. I'm a bit concerned about the new RSV vaccines for adults because Pfizer, without a emergency status, had about 36K in their stage 3 clinical trial with about 2.4% severe reactions, with GSK having about 24,000 in their study with about a 4% severe reaction. GSK used an adjuvant, which seemed to give them higher efficacy, while Pfizer did not. This is just my brief summary without the benefit of a PhD or MD education. I believe both studies were done over 6 months. I will continue with my flu and COVID booster vaccines, and I think I'll wait a bit longer to learn more about the RSV vaccines before getting an injection. I do wear an N95 mask indoors. I would appreciate your feedback.
No, this is great, Marianne. And actually, I was just checking because the other day I got a text from one of my colleagues, David Wertheim. He's our head of allergy and immunology here at what's now Optum Tri-State. And he had a similar question. He's like, are these true? Was it 36? Was it 24? What were the adverse reactions? What are the recommendations? So this is why for this first year, it is being recommended as shared decision making. And so what is that? If a person's 61, completely healthy, no medical conditions, that may not be a person that you have jumped to the front of the line. Let's say you've got someone who's 86, they're overweight, they have hypertension, they have high cholesterol, they have some other issues. That's someone you're going to say, listen, we're seeing probably 15 to 25,000 deaths every winter from RSV in the adult population. We're seeing lots of hospitalizations. Are they going to be around children, right? There's a lot that goes into this. That's a person that you're going to say, hey, from a risk benefit, even if these are the numbers that hold, you would make that recommendation. Next year, right? Next fall, we'll have, we anticipate probably millions of people vaccinated. We will have much more data. And then we'll start being able to ask that 61-year-old, otherwise healthy person, what's the risk benefit there? And then we'll kind of see how we go. But no, I think this is reasonable. I think, as Paul Offit always points out, and I think this is really important, is that, we need the science. We need the data. This is the data that we have right now. We only have about 60,000 individuals in these studies. We will have data on 1 million people, probably more by next year, and that will help with the decision making.
Janie writes, I don't recall that you recommended Paxlovid for teenagers or young adults. since they generally fare pretty well with COVID, especially having been vaccinated. My son received 2 doses, first generation Pfizer vaccine, when he was 12. He's now 14. My daughter has 3 doses of first gen Pfizer. School just started. They're finally done with masks. Should I put them on Paxlovid if they get COVID? We have a family member with long COVID, and I'm concerned with Dr. Topol's finding.
All right, so there's a lot to unpack here, and I'll discuss Dr. Topol's findings last. Paxlovid is indicated down to about 12 years of age, and there's also about 44 or 40 kilogram weight. So there's sort of a weight and an age on the lower end there. As far as the FDA approval, but the reason I say 40, 44, they're not going to like 39 or 45, but you wouldn't do this if there weren't any other reasons. So, it's a risk benefit here. And I see we're going to talk about long COVID in a second, but it's a risk benefit. If you said, oh, I have a 14-year-old child, they're morbidly obese, they have diabetes, they have, congenital heart issues. Okay. Yeah. That's someone that we want to talk about treatment. But if you say, my son is 14, he's vaccinated, he's otherwise healthy, then we're not recommending Paxlovid in that context. So not everybody gets Paxlovid. But I see you bring up the issue of long COVID. And that's one of the challenges. In a 14-year-old, if they get COVID, do we have compelling evidence that Paxlovid is going to significantly decrease that risk? There's some suggestion. That's not really an indication. We need more science. So that's not something we're currently recommending at this point. If you said, oh, that family member is, me and my husband and one other sibling, okay, then you start asking questions. So Dr. Topol's Substack. So this is not actually Dr. Topol's findings. If you look at this, Dr. Topol is merely sticking in his Substack the research findings of other folks who actually did the research. So I know Dr. Topol's name was on one of these long COVID review articles. And I know in this is actually a mention of the VA study where they talk about, continued issues in certain individuals 2 years out. We've talked a little bit about that, and certainly, long COVID is an issue. In the study that Theodore Iwashina and colleagues, covered 208,000 veterans, they actually were looking at individuals continuing to have some risk out as late as 2 years. So yeah, this continues to be a concern. And I think, as we've talked about many times, we're not just concerned about ending up in the urgent care, the ER, the hospital, the ICU, or not surviving. Probably, as far as numbers go, this is one of the biggest concerns is long COVID, and what actually can we do to prevent that from happening?
And remember that VA study is not the same age group as Janie's kids.
Yeah, I don't think anyone in the VA study was 14.
We would hope not.
I hope no 14-year-old veterans.
Yeah. Okay. Finally, Lisa writes, I was positive for COVID August 30th. We'll begin Paxlovid today. My mom, today is the 31st. Very good. My mom lives with me. She is 88 years old and has bronchiectasis. Of course, my fear is that I have passed this to her before I began feeling ill. Would you play it out for me if she tests positive? My husband, my mom, and I have all been vaccinated and boosted as many times as we could. She would go straight to the ER. That's a question. Once there are no steroids for at least a week, and would I ask for monoclonals or Paxlovid for her? What else should I be asking for her if she tests positive?
Okay, so this is great because it's always nice to sort of do a real world example of what happens, right? So your mother's 88 years old, so already high risk bronchiectasis. So this is a pulmonary abnormality where you actually have like this fixed dilation of your bronchioles, so the breathing tubes. So again, adding to the high risk. So 88 years old, chronic lung disease. So this will be an individual who has a non-zero risk of progression, even having been vaccinated and boosted. So this is a person that would qualify for treatment. So number one, as we were saying, Paxlovid. So what you want to do is you want to reach out to your provider, her provider. What are her other medicines? Are there any drug-drug interactions that need to be addressed? What is her kidney function so that the Paxlovid can be adjusted? And we've talked about the fact that there's now data showing that you can safely use Paxlovid all the way down to an individual on dialysis. So it's really going to be only the drug-drug interactions that we're most concerned about. At this point, Remdesivir is number 2, molnupiravir number 3. We do not have any current monoclonals that work, so just forget about the monoclonals. That's it.
So she does say here, Daniel, once there are no steroids for at least a week, should I ask for Paxlovid? That's too late, right?
So you want to get treatment within the first 5 days, first 5 days of symptom onset.
Right.
And so that's one of the things you want to do is watch your mom, see how she does, try not to give her, like if you haven't given her it already, right? You're still in that transmission period. So you want to keep mom safe. But if she starts getting symptoms, if she gets COVID, which is symptoms and a positive test, then you would want to treat her within the first 5 days. And yes, no steroids in the first 5 days. You wait until the second week, and only in the second week if the person has an oxygen saturation less than 94%.
That's TWiV, Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.